This is Rachel Hine and Heather Levitas, Duke Plastic Surgery residents on the Resident Review, a Duke Plastic Surgery podcast. This lecture series is designed to aid in preparation for our yearly in-service examination. Our goal is to take you through high-yield topics along with experts in their respective fields in order to maximize your knowledge and potential scores.
Today we have Dr. Clancy joining us. Dr. Clancy did her training at the University of Southern California and has been on the Duke Plastic Surgery faculty for the last couple of years. She specializes in breast reconstruction as well as lymphedema surgery and has started a lymphedema practice at our Duke Raleigh Hospital. Thank you, Dr. Clancy, for joining us.
Thank you for having me join you guys today.
So today we're going to be talking a little bit about lymphedema. Dr. Clancy has done a lot of work in this, and she's setting up her practice in Raleigh to see new patients for lymphatic venous bypass as well as lymph node transfers. At first, we'll talk a little bit about what lymphedema is. Lymphedema is a progressive condition characterized by local or systemic failure of lymphatic transport. There are two different kinds of lymphedema, primary and secondary. Primary results from abnormally formed lymphatic channels resulting in congenital lymphedema or lymphedema developed later in life. Secondary lymphedema results from destruction or pathology of normally formed lymphatic channels. Heather, can you talk a little bit about the role of the lymphatic system?
Sure. So the primary role of the lymphatic system is to remove interstitial fluid from the body and return lymph, which is composed of protein and fat, back into the blood circulation. It plays a critical role in the immune system and response. When the lymphatic system is interrupted by primary or secondary lymphedema, an accumulation of lymphatic fluid occurs. This increases the osmotic pressure and leads to fluid collection in the interstitium. This then leads to a chronic pro-inflammatory state. This results in ongoing inflammation and formation of fibrosis, decrease in lymphatic channels, and an increase in subcutaneous adipose tissue.
Exactly. And there are different types of primary lymphedema, which we'll mention briefly here. These are often tested on our in-service exam. So when we talk about primary lymphedema, we talked about how this is from abnormally formed lymphatic channels, but it's characterized by an early onset of symptoms, a lack of inciting events, or a positive family history. The first one we'll talk about is Milroy's disease. This is an X-linked autosomal dominant form of primary lymphedema. It typically presents at birth with unilateral pitting edema, and patients exhibit normal growth and normal MRIs when studied, and there can also be ocular involvement. For lymphedema praecox, this is a non-congenital form of primary lymphedema, so this typically does not occur at birth, but it occurs before puberty. And then the third one that we'll talk about is lymphedema tarda. So this is another example of primary lymphedema. It does not manifest congenitally, but it mainly manifests midlife. So Milroy's is at birth, lymphedema praecox is before puberty, and lymphedema tarda is midlife.
And also for lymphedema praecox, the other thing that you might see is Mage disease sometimes. That's the other kind of terminology. And most geneticists think that there is an autosomal dominant pattern, so that may or may not come up on your in-service.
Awesome. Thank you, Dr. Clancy.
Just out of curiosity, have you seen any of those patients, Dr. Clancy?
I actually have. My practice is still in its infancy of building, and I see a lot of upper extremity lymphedema, secondary lymphedema from breast cancer, and I actually see a fair amount of lower extremity lymphedema, most of which that I have seen thus far have fallen into kind of this primary lymphedema situation. So I have seen a couple of patients thus far, even in the last year, that have had, lymphedema praecox and one that I think probably has an undiagnosed Milroy's disease, and so I think it's definitely a little bit more prominent than you would even imagine when you start looking at all the patients with kind of primary lymphedema. it's interesting because sometimes they were never diagnosed earlier, and then just have this kind of slow onset of progressive swelling, and don't know what causes it, unilateral, bilateral, lower extremities, in otherwise healthy people. And so a lot of times they go to a therapist first, and then the therapist says, well, why don't you get evaluated by a vascular surgeon first, which sometimes is the first person that they see before they get over to somebody who's doing lymphatic surgery.
Awesome. Thank you so much. So I think that's a good segue into talking about some of the types of secondary lymphedema. Rach, would you want to talk about that?
Sure. So secondary lymphedema is non-congenital lymphedema, so it comes from some inciting event, and typically patients will have a history of previous trauma, surgery, or radiation. Symptoms can occur months to years after the inciting event. Surgery is the main cause of secondary lymphedema. The incidence of upper extremity lymphedema following surgery and radiation for breast cancer can range from anywhere from 4 to 49% in the literature. Sentinel lymph node biopsies alone have up to 7% incidence of lymphedema, 39% after an axillary node dissection, and 66% after inguinal lymph node dissection. So a lot of these patients will present after surgical intervention. The most common that we're tested on is the filariasis. It's the most common cause of secondary lymphedema worldwide, and that's typically in underdeveloped countries where we see that more often. Dr. Clancy, any thoughts?
No, I think your primary are going to be that you're going to see, at least in the United States, is going to be secondary lymphedema from cancer, ablative surgeries. When you add, particularly for breast cancer, when you add axillary node surgery plus radiation plus some of the different types of chemotherapy that are used, that's where you start getting into the higher numbers, and the range is all over the place. But I think consistently, most people believe that there's probably about a 30 to 40% risk of developing upper extremity lymphedema after axillary node surgery and radiation, which is pretty high. So you do always have to have that in the back of your mind when you're seeing lower extremity or other types of lymphedemas that haven't had surgery, in terms of have they had any type of travel history. But it's in terms of filariasis, you're not going to be seeing that on a regular basis, at least in the United States.
So the next thing we'll talk about is diagnosis of lymphedema. Heather, do you kind of want to talk about the different stages of lymphedema that we see and how it's worked up?
Sure. So the first thing you want to do when you see a patient who you suspect may have lymphedema is you want to rule out other diagnoses, including venous insufficiency, deep vein thromboses, congestive heart failure, and renal failure. And then once you've kind of ruled those out and your suspicion is moved more towards lymphedema diagnosis, you want to look at staging them. So stage 1 would be patients who begin to experience early progressive swelling from distal to proximal. This can be corrected with elevation compression. Generally, you observe some pitting edema. And then in terms of following the staging progression, it's good to continually take serial limb measurements so you can kind of gauge the progress of the lymphedema. Stage 2 would be a progressive fibrosis with adipocyte proliferation and actually less pitting edema. There's also a decreased responsiveness to these sort of non-surgical therapies that are more effective in stage 1. Of note, a stemmer sign is when the skin cannot be tented. Typically, this is done at the base of the second toe or dorsal skin of the finger or toe, which distinguishes lymphedema from edema from venous insufficiency. And this is a result of decreased skin pliability. And then stage 3 is lymphostatic elephantiasis. The tissues demonstrate induration and absence of pitting and dermatologic changes like pseudo-orange, hyperkeratosis, and polypoid nodules.
Yeah, and so for the staging, the staging criteria that you guys just went over is most consistent with, I think most people are using it, the ISL, International Society of Lymphedema staging system. There are multiple different staging systems out there, but I think this is the one that is most readily kind of incorporated with and most people use, although there are, just to know, there are some other lymphedema staging ones that are out there. This is this is a good overview and kind of goes into, like you mentioned a little bit, in terms of the interventions that can be used for lymphedema, and which ones of the interventions do tend to work for certain stages and which ones might be more appropriate. So as we kind of get into talking about the actual interventions and what can be done, the staging is really important for that.
Thanks, Dr. Clancy. Next, I'll briefly mention the workup. So there are different studies that are usually done for lymphedema. There are 3 imaging studies that I'll briefly talk about. The first one is radionuclide lymphoscintigraphy. So this assesses the function of the lymphatic channels and drainage into the lymph node basin. It can evaluate the severity of lymphedema and assess for anatomical abnormalities such as obstruction or reduced lymphatic channels. This one is the most commonly used. The second one is MR lymphangiography, and this has been developed to provide superior high-resolution anatomical images of the lymphatic system and characterize the soft tissue changes associated with lymphedema. The third one is indocyanine green lymphangiography, which offers real-time visualization of lymphatic flow and is helpful in patients who cannot undergo MR lymphangiography. Dr. Clancy, in your practice, what imaging modalities do you use for workup for these patients?
So I think regular lymphoscintigraphy definitely has a role, and like you said, is kind of probably the most commonly used test that the radiologists perform. So it's easily ordered by anybody for kind of workup or diagnosis of lymphedema. So if you have somebody who is kind of don't really know where they stand, is this a venous problem, is this a lymphatic problem, that will help you kind of delineate lymphedema versus some other reasons. But I and a lot of people use ICG lymphangiography as a primary diagnostic tool for this, because it gives you a lot of information, and particularly in real time, to also identify whether or not a patient would be a good candidate for an LV bypass versus a lymph node transfer. It is very it's very easy to do. It can be done in the clinic. It's very easy for the patients to undergo. Pretty straightforward to learn how to do it, and it's not expensive, which is a big thing. MR lymphangiography is also, like you mentioned, is a great test and gives you wonderful, unbelievable images. Similar to mapping the lymphatics like the ICG, and potentially doing venous mapping as well if you do it in that fashion. But it can take a long time. It's an expensive test to undergo. It's not readily available at most places. Unfortunately, here at Duke, we don't have the capability, or we're not offering that to patients right now. So I think it's very useful, but I don't think it's as the primary test. I think lymphoscintigraphy, I think ICG lymphangiography, and if you have the capability, I certainly think MR lymphangiography is a great test if you can get it done.
All right, Heather, your turn. It's your turn.
All right. Okay. Moving on to treatment of lymphedema, Dr. Clancy already started touching on this, but there are 2 different options, non-surgical and surgical. Surgical or non-surgical treatment would include things like elevation, skin care, elastic stockings. The sort of threshold that we like to use is 20 millimeters of mercury for the pressure, physical therapy, and pneumatic compression devices. These sort of non-surgical modalities are really lifelong commitments for patients and requires a high level of compliance. For surgical treatments, the goal of a surgical treatment is to improve the patient's functional status and lessen the burden of some of these non-surgical therapies by reducing reliance on compression and really to decrease the risk of recurrent infections. There are both physiologic surgical procedures and ablative surgical procedures. So those are sort of the two categories. Physiologic procedures promote anterograde flow of lymph via either bypass or induction of lymphangiogenesis. They should be considered early in the course of the condition to optimize lymph drainage. And then ablative surgeries really kind of debulk the areas of lymphedema to reduce morbidity. They may be performed at any stage of lymphedema during the course of lymphedema progression and are usually reserved for later stages when physiologic intervention is not really possible.
So
Dr.
I'll just
Clancy,
make a comment. Go ahead.
Yeah, go ahead.
No, go ahead. Go ahead.
Oh, I was just going to ask kind of when you see these patients, how do you decide who is going to get what and when do you start non-surgical treatments? How long do you do non-surgical treatments before you start discussing operative intervention?
So it's a good question. So usually for the most part, by the time the patient comes to see me in clinic, I'm not the first stop, and typically a plastic surgeon is not the first stop in their treatment kind of course. So I think for any of these things that we're going to talk about in terms of operations, there really has to be a pretty strong partnership with your therapist and your certified lymphedema therapist and your physical therapist or occupational therapist who are dealing with these patients. So the mainstay of all of these different types of kind of treatments is that patients are optimized as much as possible with their non-surgical treatments, which if you kind of lump in the kind of term that a lot of people use is complete decongestive therapies, and that includes the elevation in the skincare and the stockings and the compression pumps. And so when a patient comes in to see me, if they have not, seen a certified lymphedema therapist, if they've just seen a therapist that kind of put them in a sleeve and said, good luck with this, then I'll send them to somebody who will do proper evaluation and proper measurements and really get them on a program. And what they typically do is, and they usually have them in an active treatment program for a period of time to kind of optimize things. And active, I mean they're going into the therapist, they're on the several times a week basis or weekly basis to the point where they kind of stabilize, and then they send them out on treatment that they continue to do at home. So for the surgical interventions, when you talk about patients who are good surgical candidates, they really have to have kind of optimized and maximize the non-invasive, non-surgical treatments as much as possible. So for some people, that may be 6 months or more. Some people that may be, 3 months type of situation, but typically not less than 3 months because it takes a period of time. So I don't have like a definitive time frame, but I would say roughly between 3 to 6 months at least, showing some stabilization of where they are before introducing any type of surgical interventions, which we'll talk about next.
Thanks, Dr. Clancy. So next we'll talk about physiologic operations. There are two commonly performed transfers that we do, which are lymphaticovenous anastomosis or bypass and vascularized lymph node transfers. So the first one is lymphaticovenous anastomosis. This is a bypass operation that serves to redirect excess lymphatic fluid into the venous circulation by anastomosing superficial lymphatic vessels at the dermis to nearby venules. Prior to surgery, indocyanine green lymphangiography is performed to determine the location of the lymphatic vessels. This is typically injected distally, and a near-infrared camera is used to detect the channels. Their course is traced, and transverse incisions are made over the marked channels. Isosulfan dye is injected subcutaneously distal to each mark to aid in identification, and then the lymphatic channels and venules are identified and anastomosed end-to-end or end-to-side with 11-0 or 12-0 suture. Patency is confirmed by visualizing anterograde flow. Usually there are several done in each operation. And then the second one that I'll talk about is the vascularized lymph node transfer. This technique is used when the native lymph node basins are dysfunctional, so this can be after radiation or lymphadenectomy. This technique is thought to promote local lymphangiogenesis through production of vascular endothelial growth factors. Common donor sites include the supraclavicular lymph nodes or superficial inguinal lymph nodes. The supraclavicular nodes are located inferiorly within the posterior triangle of the neck in the fat between the omohyoid muscle and anterior scalene muscles. This is supplied by the transverse cervical vessels. And when you're performing this, you need to remember to take caution when harvesting on the left side to avoid injury to the thoracic duct. This can be tested on our in-service. And usually contralateral nodes are harvested to avoid further exacerbation of lymphedema. The superficial inguinal lymph nodes are supplied by the superficial circumflex iliac vessels from the femoral artery and are located in the subscarpus fat between the inguinal ligament and groin crease. You need to remember to remain superior to the groin crease in order to not disrupt the lymph nodes that drain the lower extremity. Some examples are used kind of at the time of breast reconstruction. You can include the lymph node basin, or you can do a lymphovenous anastomosis. Dr. Clancy, can you talk a little bit about your use of each of these?
So yeah, and I think this kind of goes back to what's the right surgery for the right patient. And so when you're kind of looking at how to identify whether or not you're going to do an LV bypass or anastomosis versus lymph node transfer versus a combination of both of those at the same time, you kind of need to know whether or not patients have intact functioning lymphatics. So if they do, they are, if they do, and there are targets that you can look for that are identified on either the MRI or the ICG lymphangiography, then they're a candidate potentially for that at earlier stages, which we talked about earlier. Stage 1, early stage 1 into stage 2 have better results than trying to do that type of procedure in somebody with a stage 3 lymphedema. Same goes for the vascularized lymph node transfers. The studies have shown that the results are better in people with earlier stage lymphedema, and those are picked up on the earlier side. So that goes to identification and proper kind of stratifying your patient population into what makes most sense. For the LV bypasses, in addition to kind of what you talked about, I also use a vein finder, which is somewhat useful if somebody is not super edematous or fibrotic, to find those superficial veins and try to target where you're doing your anastomosis. That's also kind of a beneficial thing. The vascularized lymph node transfers, you mentioned 2 of the many different options in terms of transferring lymph nodes or lymphatic tissue. I think in terms of decisions, in terms of looking at like the different options, everything that you said in terms of you have to be careful with the supraclavicular in terms of your injury to a thoracic duct or other lymphatic channels, even on the right side. And with the groin lymph nodes, you have to be careful. You have to do reverse mapping. And I think with those two, and some people do lateral, I don't, but some people do lateral thoracic, lateral chest, lymph node. But a lot more people are looking to omentum and omental flaps, which can be split. You can do 2 different transfers with a single harvest, as well as potentially mesenteric lymph nodes, which both have a very low rate of donor site lymphedema. There's other issues that can potentially develop, obviously with laparotomies, but those are also two other modalities which are useful. So I think in terms of looking at your lymph node transfer options, to have multiple ones, and I think most people probably that are doing a fair amount of lymphatic surgery, you have a couple different kind of go-tos. There aren't people who are doing, I'll do supraclavicular today, we'll do a groin next, we'll do a mental. And unfortunately right now, and it's not going to come up on the in-service most likely, but there's no consensus in terms of what's the best donor site for your lymph nodes. And hopefully we'll have some information about that in the next, 5 to 10 years or so, but at this point you don't. So the things that you can get tested on, things that you need to know are the things that are standard, which is kind of what you said, things to look out for.
I have a question about the transfers. How many people are doing them at the same time as like an axo dissection? Or is anybody doing this prophylactically or potentially even maybe like after lymphedema occurs, they're at the stage of breast reconstruction? What do these kind of operations look like? Are they doing the reconstruction?
So in terms of what people are doing in terms of primary lymphatic reconstruction or reconstruction at the same time, we'll just talk about breast reconstruction or axillary node dissection. So there are several groups and studies going on about doing just that in terms of primary lymphatic reconstruction. What that looks like is basically lymphaticovenous anastomosis at the level of the axilla where those lymphatic vessels are cut, and identifying those and reanastomosing the ones that have been cut to a vein in the area type of thing. And so that doesn't go down into the lymph node transfer as a primary, but preliminarily some of the results from doing, those primary lymphatic reconstructions is very favorable, although certainly we need a lot more long-term follow-up and long-term data in terms of whether or not it's actually going to be as functional as we think that it is. In terms of doing lymph node transfer at the time of a breast reconstruction. So yes, you can do combination flaps where you do groin lymph node skip flap, i.e. T-bar kind of reconstruction, where you do everything at the same time, and that certainly has been described and has been shown to have some good results. Just anecdotally, just by doing a primary, if you have a delayed reconstruction, just by doing a primary deep or flap reconstruction, upwards of 15 to 20% of patients, their lymphedema will get better just with that, without doing a lymph node transfer. So in my mind, if you're going to do that, it might be better to separate them. Although certainly you can look to do them at the same time. And in terms of heterotropic placement of the lymph nodes at the time of the reconstruction. So there's lots of different potential ways of doing this, and I think we just need more. We need more numbers and we need more information to say what definitively is the best treatment route for these patients. Because right now I don't think it's very standardized, which is unfortunate. There's more people doing lymphedema, and there's more information, that we're gathering. But I still think that that we need to have some more information.
Heather, do you kind of want to talk a little bit about what postoperative care looks like for these patients and outcomes?
Sure. Yeah, that's a perfect segue to talking about what some of the outcomes are. I know Dr. Clancy kind of touched on the fact that we don't have a ton of data, but there is some out there. So I guess I'll talk about that first. There are some reports that show that with the lymphatic-venous bypass, there is somewhere between a 35 and 50% reduction in extremity circumference or volumes with mean follow-ups at least a year. So it can take a long time for the patients to see any kind of visible change in the circumference or volume of their extremity. There are also studies that show that subjectively about 96% of patients report improvement in their symptoms, and in this particular study by Chang et al., there was a mean volume reduction by about 42%. So that falls into that same 35 to 50%. The same paper revealed that there is a greater benefit when the bypass is performed in early stages of lymphedema over advanced lymphedema. And then as far as outcomes with the vascularized lymph node transfers, there's a similar reported incidence of volume reduction at about 30 to 60% volume reduction. It has shown to be superior to non-surgical treatments, at least of the upper extremity. And then in terms of patient-reported outcomes, studies have shown that quality of life improvements can be measured in both domains for upper and lower extremity lymphedema patients. But I know it can take a while for patients to really see the outcomes of these procedures, and we have to counsel them to be patient. And then in terms of go ahead, Dr. Clancy.
So I agree. So the vascularized lymph node transfers typically at least a year before they really see results, which is a long time to wait. Versus LV bypasses, which technically if they're functioning and they're working, you're going to see results definitely, or the start of results more quicker than a year to 2 years out, which is certainly a long time, and that goes really into your preoperative counseling with the patients, which is so important. And one of the things with all of the studies in terms of volume reduction, the most consistent thing is the subjective improvement of symptomatology. And so most of these patients are never going to get off of their compression garments. I mean, that would be ideal if you have somebody who you can get away from all of the non-invasive modalities that they have to deal with, but it definitely makes life easier, and subjectively they feel better. And so when you're counseling patients in terms of what the reasons are and what the expectations are, it's not that they're going to get a 50% volume reduction and not going to have to wear their compression garment again. So that's definitely something that I think when you look at the outcomes, at least that we have right now, that plays into kind of how you talk to these patients preoperatively in terms of setting expectations.
As far as complications go, I heard you mention reverse lymphatic mapping, especially for the iatrogenic lymphedema. Can you talk a little bit about what that is and how you use it in your practice?
So, particularly for lower extremity. So for groin, if you're going to take superficial groin lymph nodes based off of the superficial circumflex vessels, definitely doing reverse mapping to make sure that you are not taking they're typically the more medial. They can also be part of the superficial system, but the more medial primary draining lymph nodes of the lower extremities, so as obviously to not induce a lymphedema for the lower extremity, which would be obviously quite traumatic for the patient. So that's, it's readily done. It's also done for the upper extremity in terms of in conjunction with reverse mapping in conjunction with axillary node dissection, so as to identify potentially primary draining lymphatics of the upper extremity. And if those are different, then the breast ones that need to be taken, leaving those other ones potentially behind so you don't incite the issues with lymphedema. Not readily is used for supraclavicular, not needed for omental or mesenteric lymph node transfers, but definitely for lower extremity for groin node transfers.
So in brief, just kind of summing up everything we've talked about for physiologic operations, for these two kind of surgeries, they're better done in the earlier stages before irreversible changes happen. Lymphaticovenous anastomosis will primarily address lymphatic channels, whereas the node transfer is good for patients that have had damage to the primary lymph node basins, so like radiation, lymph node dissections, those kinds of things. For outcomes, it sounds like both of them have both subjective and objective outcome measures, and you generally see those changes. Some say 3 to 6 months, but you definitely say 1 year before you can say anything definitive. And then, a stress complication would be iatrogenic lymphedema, which can be mitigated by doing reverse mapping.
Exactly.
Okay, great. Heather, do you want to talk a little bit about ablative surgeries?
Sure. So the main goal of ablative techniques is to actually remove excess skin or subcutaneous tissue, and they serve to decrease the bulk and improve functional status of these patients as well as their hygiene. These procedures are typically indicated in higher stages of lymphedema that have progressed to fibrosis and fatty infiltration. So the first procedure that we were going to talk about is the Charles procedure. This technique is the earliest technique and was described as a resection of the skin and subcutaneous tissue to either the deep fascia or underlying epimysium. The wounds are then resurfaced with skin grafts. The skin grafts may be taken actually from the resected tissue. This abates the superficial lymphatics and may cause exacerbation of lymphedema along the foot if it's done in the lower extremity. Then the Homan technique, which is a staged subcutaneous excision, it's just another method to debulk areas of chronic lymphedema without the need for skin grafting. Longitudinal incisions are made with wide elevation of skin or subcutaneous flaps. Fibrotic subcutaneous tissue is then resected down to epimysium. Redundant skin is removed, and this is repeated in stages until the extremity is sufficiently debulked. And then finally, there's suction lipectomy. This has been used in advanced lymphedema patients who do not have significant pitting edema. Large volume lipoaspirate may be removed, and it's important to utilize early compression after the procedure and really for the rest of their lives in the patients that you're performing suction lipectomy on. And then I guess, Rachel, would you want to just go through some examples of some conditions that may benefit from these sort of more ablative techniques?
These examples requiring ablation have been tested on in our previous in-service tests. So the first one I'll mention is paniculus morbidus. This is a severe form of abdominal lipodystrophy. It prevents weight loss, and so paniculectomy with primary closure is typically performed for these patients. Another example is liposuction. This can be performed on lower extremities with severe bilateral edema and fibrotic changes. We have been tested on penile lymphedema, so other techniques do not work, but excision or a stage excision and grafting will work for these patients. And then this year we were tested a lot on chronic lymphedema. If the patients have infections, it's important that they're treated, and the treatment of choice is typically excision over liposuction for these patients. Dr. Clancy, what are your thoughts?
No, I think that they're all like good examples. I mean, I think that on the spectrum of, I think of these as physiologic and non-physiologic interventions, but on the spectrum of what you're calling the ablative surgeries, where you're trying to decrease bulk and decrease the kind of fullness, it's easy to understand the paniculus, the massive paniculus that you need to, the massive lower extremity lymphedema that is not going to respond. But the ones that kind of fall into that like category where they're pretty severe, maybe they're early stage 3, maybe they still have some pitting, they still might benefit from having a physiologic intervention, whatever that may be, as well as having a debulking. And so there is a caveat that patients don't necessarily fall into only physiologic or only ablative type of interventions. And so many times I would recommend that they, have the physiologic, initially, and then come back, and then whatever fibrofatty deposition and component, if they still have a significant component of that, which they will if they have advanced disease, then at that point entertaining liposuction only or liposuction with direct excision to really decrease the fullness of the limb. That being said, liposuction only has been around, and Charles' procedure has been around for a long time. Liposuction only has been around for a long time for primary treatment of any type of lymphedema, and it is 100% effective. So you can liposuction a lymphedema patient regardless of what their stage are, and you can make them better in terms of if you look at circumferential measurements. The caveat to that is that they always have to wear compression garments after they have that forever. Because you haven't done anything to address the fluid component, you're only addressing that extra kind of fibrofatty deposition that happens. And so liposuction is great. It's not, it comes with the the handcuffs of having to wear the compression garments forever. So I think, it's good to kind of think of these things as two separate categories, but understanding that there's a lot of kind of crossover between the two of them, except in those people that are really those severely advanced elephantiasis that are going to be better served by, an excision type procedure over anything else.
A lot of what we're tested on and a lot of what's important for these workup of lymphedema patients is understanding kind of where they are and where they and what kind of operations will best suit them. And I think that kind of goes into an algorithm, and we have a little bit of one, especially for the physiologic procedures. I think we talked a little bit about it earlier, but Heather, do you mind mentioning that briefly?
Yeah, and this is a nice sort of like summary to everything we've kind of talked about.
Mm-hmm.
But in general, patients are amenable to physiologic interventions if they are responsive to non-surgical therapy and have significant pitting edema. Patients are not amenable to physiologic interventions such as the bypass or the lymph node transfer if they have really no improvement with non-surgical techniques and no longer experience pitting edema, which is a sign of fibrosis and increasing adiposity. Dr. Clancy, did you have something to add?
No, I agree.
Okay, awesome. And then when choosing between the two procedures, it's important to take into account the reasons for the lymphedema. If they're secondary to surgery or radiation therapy and do not have suitable lymphatic vessels based on the imaging techniques we talked about earlier, you might want to go with the vascularized lymph node transfer. If they do have suitable lymphatic vessels to bypass, you may include this in the treatment regimen or perform alone if the lymph nodes were not destroyed in earlier procedures.
Agreed.
Well, awesome. Well, I want to thank you so much for being here with us today and moderating this session. I think this is a great kind of outline for residents and when we're studying for in-service exams. I appreciate your time.
Yeah, thanks so much, Dr.
Thank you. Yeah, thank you for having me.